Okay, everybody. Welcome to Chapter 19. We'll be talking about the special senses today. Now, the special senses could be summarized as our sense of smell, our sense of taste and vision, our sense of balance and hearing. We also have somatic senses, our ability to feel touch, pressure, vibration, our ability to sense warm and cold, our ability to perceive pain, and our ability to sense our body's position in three-dimensional space. Um, Essentially, the only way that we can react to the environment around us is to transform all of these different types of stimuli into some sort of an electrical signal. And that is the job of the sensory receptors. These are located in our special sense organs. You cannot take these sensations directly and impute them to the brain and have the brain understand them. So what we are tasked with today is to try and figure out how we take something like light or like sound or like smell and turn it into an electrical signal that the brain can interpret and that allows us then to act accordingly, to respond to that stimulus and adapt now again to our environment. Visceral senses are those that come from our internal organs, and somatic senses are those that come from the surface of our skin. And we get information from both the inside and the outside of our body via the peripheral nervous system. These leads come through the dorsal root ganglia into the backside of the spinal cord, and then they ascend all the way to the brain stem. From there, they head to the midbrain and then to the thalamus, which is the gateway to the cerebral cortex. And then the thalamus determines which sensations are going to reach our conscious awareness. And then we act accordingly. We respond to that stimulus in an appropriate fashion. Sensation could be defined as the conscious or subconscious awareness of change in the external or the internal environment. It requires a stimulus, a receptor, a neural pathway, and a brain region for integration. Now, this is something that's absolutely vital for our survival. You could probably define the very first ever nervous system, so to speak, as something as simple as positive and negative chemotaxis, which is a quality that you see in single-celled organisms where they will either move towards or away from a diffusible chemical in their environment. For instance, you might see an amoeba move towards a food source as a physiological reaction to perhaps glucose diffusing in an aqueous environment. Or you might see it run away from toxic or damaging conditions. And this is a behavior that is selected for that ensures the survival of that organism. The elaboration of that is the nervous system, where we're able to perceive and respond to changing conditions in our environment in a manner that allows us to stay alive. So, what are some of the characteristics of this ability to interact now with our environment? Well, perception causes conscious awareness, and this takes place in the cerebral cortex. Now, the cerebral cortex is that part of our brain that deals with our perception. It is gray matter, and as a result, it is involved in signal processing. Adaptation is the decreased receptor response that occurs during prolonged stimulation. This results in decreased perception and adaptation with speed that varies according to the receptor type. Rapid adaptation are seen in sensations such as pressure, touch, and smell, and slow adaptation are seen in perceptions such as pain, body position, and chemical levels in the blood. I can give you an example. If you've ever worked in an animal care facility, one of the things that you'll notice the minute you walk in is the striking smell of ammonia. This is the result of the decomposition of urine. And if you stay in that location for several hours, or even if you come back the next day, one of the things that you might notice is that you don't smell that strong ammonia as much as you did before. And this is a result, again, of adaptation. Slow adaptation, as seen in pain, body position, or chemical levels in the blood, means that we do not lose our sensation of these particular stimuli over time. Now, if you think about it, it's very important that these particular stimuli stay in our conscious awareness. Pain, for instance, is a very important signal telling the body to deal with an injury. Our position of our body in space is vital to us coordinating movement. And chemical levels in the blood, well, here we're talking about things like oxygen and carbon dioxide, and obviously we want to be critically aware of that in order to keep homeostatic levels of these life-giving gases in our system. So let's talk about some different types of sensory receptors. Free nerve endings respond to pain, thermal sensation, hot or cold, tickle, itch, and some touch receptors. Encapsulated nerve endings respond to touch, pressure, and vibration. And there are specialized cells, such as those in the inner ear, that respond to sound in the cochlea and our sense of balance, if we're talking about the vestibular apparatus. And there are photoreceptors in the retina of the eye that respond to light and color. Mechanoreceptors respond to mechanical stress, such as deforming the shape of the cell due to force or pressure, such as stretching or bending. They can also respond to touch, pressure, and vibration. Thermoreceptors respond to changes in temperature, while nociceptors are our pain receptors. Photoreceptors respond to light, and chemoreceptors respond to taste and smell. Basically, compounds that either dissolve in air or dissolve in water, which can bind to these receptors and generate now an electrical sensation that we perceive as taste or smell. Osmoreceptors respond to the osmotic pressure of body fluids. These are very important in the maintenance of blood pressure. Somatic receptors are found in the skin, the mucous membranes, the muscles, the tendons, and the joints. And they're distributed somewhat unevenly. Dense concentration of receptors are found in very sensitive areas, such as in the fingertips, the lips, and the tip of the tongue. These include tactile, thermal, pain, and proprioception. Now you might say, well, why is that? Why are there so many in those locations and relatively few in other locations? And the reason is that these provide us with very important skill sets. If you think about your fingertips, right? What can you do with your fingertips? Well, you can perform fine manipulation. You can write. You can paint. You can work tools. You can read Braille. Okay. The lips have a lot of receptors because they guard the entrance to the oral cavity, and so we want to be very aware of, well, what we put in the mouth, right? What we taste. It's also important in terms of speech. The tip of the tongue, also for purposes of digestion and speech as well. So you want to have a lot of sensation in those areas. And by the same token, if you remember from our discussion of the nervous system, you also have a lot of control in those areas, a lot of motor control. So this is represented on the brain by the sensory and the motor homunculi. Homunculus means a little man. And if you map those regions of the brain that are responsible for information either coming from or going to those parts of the body, what you get is a very strange looking individual with a large face, hands and feet, and a very small body. If you look up, Google sensory and motor homunculus on Wikipedia, you'll see what I'm referring to. And it's just a representation of how much of the brain is dedicated to working those parts of the body or receiving information from those parts of the body. So, this information includes tactile, thermal, pain, and proprioception. So let's talk about tactile sensation. This includes touch, pressure, and vibration. They come from encapsulated mechanoreceptors in the dermis. Itch and tickle are basically the purview of free nerve endings. Uh, Receptors for touch are rapid adapters. Examples of these include Meissner corpuscles and hair root plexuses that detect hair movement. Slowly adapting receptors for touch include type 1 mechanoreceptors such as Merkel discs or tactile discs. Surface receptors are generally found in the epidermis. Type 1 mechanoreceptors, known as Ruffini corpuscles, are found deep in the dermis and tendons, and as a result, they don't respond until the pressure gets pretty high, because you have to remember that the dermis lies deep to the epidermis, and so it's the location of these receptors that's primarily responsible, again, for their relevant sensations. Okay, so all these have the same job, right? It's to take some sort of stimulus, some mechanical stimulus, some thermal stimulus, light, heat, what have you, and turn it into an electrical signal for the brain. Pressure. Pacinian corpuscles respond to these. These are nerve endings that are encapsulated by connective tissue that is wrapped around it in layers, sort of like an onion. These are rapidly adapting receptors, and they're widely distributed in the dermis, the subcutaneous tissue around the joints, tendons, muscles, and in the periosteum. Vibration responds to rapidly repetitive stimuli, and the receptors are the Meissner and the Pacinian corpuscles. And what you're looking at here is just a diagram showing you some of these different receptors, where you might find them. Again, this is the epidermal layer, and underneath it is the connective tissue known as the dermis. And here you can see some of these different receptors and how they look like under a microscope. So these are Meissner's corpuscles here. These are cutaneous tactile receptors, such as Merkel discs. Over here you've got nociceptors. These respond to pain. Down here you've got type 2 cutaneous mechanoreceptors. See how deep in the dermis these are, here and here. And then all the way down here you've got lamellated corpuscles, also have the ability to respond to pressure and deep touch. So again, the position of these receptors is a big player in terms of what they're going to be capable of picking up. Let's talk about itch or tickle. Itch is clinically called pruritus. It results from the chemical stimulation of free nerve endings, or of bradykinin, which is released during the inflammatory response. Tickle comes from free nerve endings and Pacinian corpuscles, and usually requires mechanical stimulus from outside of yourself. You cannot tickle yourself, right, because you're consciously aware of it. You know what's coming, so you adapt to it. The effects of attempts to tickle yourself are usually blocked by signals that emanate from the cerebellum. Remember that that's the hunk of the brain that lies below the occipital lobe and is posterior to the brainstem. There's two kinds of thermoreceptors: cold receptors that work between 50 and 105 Fahrenheit. They're found in the epidermis, while warm receptors work between 32 and 48 degrees centigrade, which is 90 to 118 Fahrenheit, and they're also located in the dermis. Both adapt rapidly, but continue slow signals during prolonged stimulus. Outside these ranges, the nociceptors take over, and we have the sense of pain. Now, a little tidbit that you may not know is that there are more warm receptors located on the posterior aspect than on the anterior aspect of the body, and this is one of the reasons that seat warmers are so effective in cars, because it is making maximal use of stimulating those receptors, so you feel extremely warm, even in an automobile cabin where the temperature might be at or below freezing. So if you want to warm yourself up, you warm your backside. Let's talk about pain sensations. Nociceptors are free nerve endings that you find in every tissue except in the brain. They can respond to any excessive stimulus. They have minimal adaptation. Types of pain include fast pain, which is acute and very sharp. It's generally well localized, and slow pain, which is chronic burning, aching, or throbbing pain, which is more diffuse and as a result not localized. Referred pain is termed visceral pain, and it is displaced to the surface. And here you can see a referred pain map. Now this is a very important clinical diagnostic tool because it gives the doctor or the therapist or the nurse some idea what might be going wrong with you if you don't have an obvious external cutaneous injury. Basically what you're looking at here are areas of the body that generate a painful stimulus if a particular internal organ is actually affected. Here you can see the classic left arm through the pec region and through the medial region of the left arm that you feel, say, during a heart attack. Liver and gallbladder pain felt around the right shoulder, the acromial region up here. Lung and diaphragm pain up near the cervical region and around the left shoulder. So all of these are very important. One that I'm intimately familiar with is pain coming from the kidney. You can see that it basically wraps around the body just superior to the navel and extends all the way down to the inguinal region and to the lateral thigh. And it feels like terrible GI pain when in fact what's happening is that the kidney is experiencing some sort of pain. This can come, for instance, from a lodged kidney stone where urine backs up into the ureter and into the kidney and actually causes damage to the nephron, to the kidney tissue. Okay, so until you experience these, it's very difficult for you to understand how strange this feels, where you think it's literally coming from one part of your body, but it's actually coming from an internal organ. Now, you might well ask, well, why? You know, why do I feel pain in this region of the body when it's actually coming from the viscera? And the reason is that the pain leads that come from these regions of the body, and as that result from an external injury, happen to hit the same area of the spinal cord as the visceral pain receptors do when they are relaying pain information from the viscera to the central nervous system. And the brain cannot tease these two sensations apart, and as a result it's perceived as pain in one of these areas. Okay, so very important diagnostic tool, the referred pain map. Okay, let's talk about proprioception. This is our awareness of our body's position in space, the movement and the weights of objects. Receptors are found in the muscles in the form of muscle spindons or in tendon organs. They're also found in joint kinesthetic receptors that you might find in diarthrotic joints. You also see them in the inner ear, in the vestibular apparatus, and they give us information about the position of our head in space, whether it's moving, whether it's still, and what's up, what's down, what's left, and what's right. Tracts lead to the somatosensory area of the cerebral cortex, also to the cerebellum, which is a very important part of the brain when it comes to motor coordination. Basically, if you were to describe the job of the cerebellum, it would be to ensure that the actions you're carrying out match what you are perceiving that you're supposed to be doing. And if they don't, the cerebellum has the ability now to adjust the motor signal that you're sending to your body so that it does match what your intended action is supposed to be. So it's very important that the cerebellum have this somatosensory information available to it. Okay, the special senses include smell, taste, vision, balance, and hearing. Let's start with smell. The olfactory receptors are located in the mucosa of the superior region of the nose. There's three types of olfactory cells. Olfactory receptors, which are made up of olfactory hairs that include chemoreceptors. These are first-order neurons of the olfactory pathway, and supporting cells, which are epithelial cells that support and protect these olfactory hairs. And then finally, basal cells, which are stem cells that produce new neurons throughout life. Now, what's very interesting about this is that the olfactory epithelia, these receptors that respond to the odor signal, are one of the few neurons that are generated within the brain on a daily basis that migrate actually through the brain from the from the occipital lobe all the way to the olfactory bulb, where they stop, they differentiate, and then they provide us our sense of smell. So there's something unique about these neurons that are born within the central nervous system that are constantly replaced that is distinctly different from all the other neurons that you find in the brain and the spinal cord, which, as we know, do not regenerate and do not repair. And there's a lot of research that's gone into trying to figure out what it is about these neurons that makes them fundamentally different from the rest of the neurons in the brain. Here you can see their location. The olfactory bulb, remember, lies on top of the cribriform plate, which is a portion of the ethmoid bone that sits in the superior region of the nasal cavity, and then these cells basically project their epithelia down into the nasal cavity, and then any molecule that dissolves in air can produce now the sensation of odor. This literally is a piece of your brain that is hanging out in the environment every day, and this is the reason that it has to be replaced, because exposure to the external environment is harsh on cells and it causes them to die, and as a result they need to be regenerated. This is also termed cranial nerve 1, the olfactory, and it has the shortest pathway back to the brain. So odors get to our limbic system very, very rapidly because this tract is very short. Other features that we want to notice about this, our sense of smell is actually a large part of our sense of taste. And if you don't believe me, the next time you have to take some bitter medicine, hold your nose and swallow, and you'll notice how much less intense the taste sensation is when you can't smell. This is also why food tends to lose its taste when you have a bad cold, because, again, your olfactory receptors are inhibited as a result of the condition that you're currently suffering from, if you have a cold or perhaps you have a sinus infection. There's genetic evidence that hundreds of odors exist. Binding of the chemical odorant stimulates the receptor, and the recognition of about 10,000 odors from the combination of primary receptor input has been cataloged. You rapidly adapt to these by about 50% in a single second. What is the olfactory pathway? Well, the first order neurons are olfactory receptors that are located in the nasal mucosa. The axons form the olfactory nerves. This is cranial nerve 1, which extends through the cribriform plate to the cranium, ultimately back to the olfactory bulb. The second order neurons are neuron cell bodies in the olfactory bulb, and the tract has axons that extend from the olfactory bulb back to the cerebral cortex, and this is an area in the temporal lobe. The limbic system is our emotional response to these odors, and this is where we evaluate a smell as being either good or bad. Normally, if you're just talking about a stimulus, you simply are able to recognize it as being a member of a certain class, but imparting a value judgment to it is the purview of the limbic system. The limbic system you could think of as our emotional brain, and it's composed of a series of structures that ring the thalamus and the corpus callosum, that include the amygdala, the hippocampus, the cingulate gyrus, the olfactory bulbs, and the olfactory tract. What these do primarily is, again, allow us to impart memory and emotional content to our stimuli. And this is just a zoom up showing you the olfactory epithelia. This is the olfactory bulb lying on top of the cribriform plate, and you can see the receptors basically extending their processes down through these little tiny holes in the cribriform plate, and this is the actual nasal cavity, and these are the odor molecules that dissolve in air and then bind to the mucus, and as a result bind now to the odor receptors of these olfactory epithelial cells, and this produces the electrical signal that we respond to and perceive as odor. Okay, so again, You're looking here at the olfactory receptors. This is the synapse between now the olfactory bulb neurons and the receptors, and this heads straight back to the brain. Okay, taste, again, is our ability to generate an electrical stimulus from molecules that dissolve primarily in water. There's 5 primary tastes: salt, sweet, sour, bitter, and umami, which is the taste of meat. Our perception of what we call taste also includes our olfactory input. There are receptors in about 10,000 taste buds that are located on the papillae of the tongue, the pharynx, and the epiglottis. These structures are generally located on the lateral aspects of the papillae. There are different types of papillae. The valate papillae lie on the posterior aspect of the tongue. The fungiform papillae are all over. They're called fungiform because they have a mushroom shape. And the filiform papillae, which have sort of a slender spindle shape, are only there for our sense of texture. And so if we look at the tongue, you can see these different papillae. The filiform papillae, the fungiform papillae, which you can't really see from this low magnification representation. The valate papillae are relatively easy to pick up. There are the lingual tonsils, okay? There are the palatines, okay? Your 4 or 5 tonsils there. The pharyngeal tonsil will be back here. This is the epiglottis, okay? So this is the root of the tongue. This is the tip of the tongue. If we zoom in on the papillae, you can see here the valate papillae. These are the fungiform, and these are the filiform. Okay, see how the filiform have like fibrous extensions coming off them. The fungiform have sort of like a mushroom cap type appearance, and the valate papillae have this very unique sort of double lobed. They've got an internal and an external aspect to them, and the taste buds are again along the lateral margins of the internal and the medial margins of the external aspect of these particular papillae. And it's the taste buds that actually produce the electrical signal that we associate with flavor, and not the papillae. So don't confuse that rough part of your tongue on the anterior surface. If you take your tongue and you rub it against your top lip, that rough feeling, those are the papillae. Those are not the taste buds. So don't confuse the two. A taste bud has 3 kinds of epithelial cells. There are supporting cells which surround it. There are gustatory receptor cells with hairs that project from the receptor through the taste pore, and this is where the actual sensation is generated. And then there are basal cells, which are stem cells that produce supporting cells, which eventually develop into the receptor cells, and they have about a 10-day lifespan. And you can see them here. These are the basal cells, the supporting cells, and then the receptor cells, these guys in the light blue, and these are the gustatory hairs. So how is it that flavor gets back there? Well, a molecule dissolves in water. The water makes it into the taste pore, and then the molecule binds to the receptor cell on the receptors, and this produces now a graded potential that's carried by sensory neurons back to hypoglossal and glossopharyngeal nerves, and then eventually back to the brain, where we perceive it now as taste and flavor. So if we look at the sequence of events in taste, we find the molecule that we're going to taste dissolves in saliva, so it dissolves in water. It enters the taste pore and contacts the gustatory hairs. This generates a graded potential, which causes the gustatory cell to release neurotransmitter. This activates the dendrites of the first-order neurons. Generally, adaptation occurs within a few minutes. There are different tastes that come from the activation of different groups of taste neurons, and this provides now the complexity of flavor. The cranial nerves that transmit the impulses include the facial nerve for the anterior of the tongue, the glossopharyngeal for the posterior, and the vagus that comes from the pharynx and the epiglottis. These project back to the medulla oblongata, which then projects back to the thalamus, which then hits the primary gustatory area of the cerebral cortex, which then projects back to the limbic system or the hypothalamus. Okay, now we get to a very different type of special sense, our sense of vision. We rely probably more on vision than any other special sense to ensure our survival. The accessory structures of the organ of vision include the eyebrows and the eyelashes, which help to protect the eyeball, and the eyelids that also protect it and lubricate the anterior surface when we blink, and extrinsic muscles that move the eyeball. These would be the superior and inferior rectus, the lateral rectus and medial rectus, and the superior and inferior obliques. And all these do is move the eyeball around in the orbit so that we can glance from side to side and back and forth and look around our surroundings. The lacrimal apparatus produces tears that wash across the surface of the eye. This has several adaptive effects. The tears are made by the lacrimal glands, which discharge them into the lacrimal ducts, which washes them across the surface of the upper eyelid, then to the surface of the eye. The tears then wash into the lacrimal canals, which then run to the lacrimal sac, which run into the nasolacrimal duct, and into the lacrimal, from there into the nasal cavity. And this is why when you cry, your nose runs. But what is the purpose of tears? Well, it is to keep the anterior surface of the eyeball moist. The reason this is important is it allows you to blink without pain, but more importantly, it provides a moist surface through which oxygen can diffuse in order to nourish the cornea. The cornea of your eye is the clear skin that's right in front of the pupil. This is the pupil here. And it's one of the few tissues in the body that has immune privilege, meaning that because it is avascular, there's no fear of rejection as a result of receiving corneal transplant. And as a result, in order to get oxygen, we have to get it directly from the air, and a moist surface allows that to occur. Here you can see, again, the lacrimal glands and the ducts, the anterior surface of the eye, and then the lacrimal sacs and the nasolacrimal duct leading directly into the nasal cavity. And here you can see the flow of tears from generation to excharge or discharge. Lacrimators are substances that cause you to tear up. Okay, tear gas, pepper spray are lacrimators, just to give you a couple of examples. If we have inadequate production of tears, what happens is that the cornea can dry out. The cornea, again, is this clear skin in front of the pupil of the eye. There are individuals that suffer from this. They suffer from a condition known as dry eye, and frequently when they blink, they tear their corneas off, and this is an extremely painful condition, and so it usually is treated with artificial tears. And there are also drugs that serve to increase the activity of the lacrimal glands so that they have adequate moisture so that they don't suffer this painful condition. This is more common in men than in women, but it is an idiopathic condition. We don't know quite exactly why it occurs, but there's probably a genetic component to it. If we look at the eyeball itself, it's got several layers that make it up. The fibrous tunic anteriorly becomes the cornea, which is the clear skin that lies on top of the iris and the pupil and lets light go through it without being scattered, but the light is bent when it passes through the cornea, and we'll talk a lot about that in just a moment. Posteriorly, we have the sclera, which is the white of the eye. The vascular tunic consists of the choroid, which lines most of the internal surface of the eye and contains blood vessels that nourish it, and the ciliary body has processes that secrete the aqueous humor and ciliary muscles that changes the shape of the lens so that you can focus on near and far objects. The iris is the pigmented part of the eye, and it can be any of several different colors, blue, brown, and green being just a few. And there are smooth muscles that dilate or constrict the pupil in order to control the amount of light that enters the eye so that we can clearly see our image. And the pupil is the hole for the passage of the light. And so if you look at the eye here, you can see what we call the visual axis. This is how the light comes from the object. Now the light that you see, you have to understand, is the light that bounces off the object that you're looking at. So it's It's the light that's actually reflected. So when you see, for instance, a red object, what you're seeing is the red light bouncing off that object and heading straight into your eyeball. Now, when the light passes into the eyeball, it goes through several transparent layers. It passes through the cornea here, at which point it is bent. The light, when it passes from the air to the corneal tissue, will actually now change its direction, and it will bend towards what we call the median. And then it will pass into the aqueous humor, which is a clear fluid that is produced by the ciliary bodies and fills the anterior chamber of the eye, this area here. Then it'll pass through the lens, which is made up of a clear protein called alpha crystalline and is enclosed in a sac and is attached to the ciliary muscles, which allow the lens to change its shape in order to focus on objects that are either close by or far away. And then from there, it'll pass into the vitreous humor, which is a clear jelly-like substance that causes the shape of the eyeball to remain relatively round. The vitreous is very interesting because not only does it provide now a clear substance through which the light can pass and eventually get back here to the retina, which is the part of the eye that's going to respond to the actual light that's reflected off the object you're looking at, but it also helps to press down the neural tunic and the vascular tunic so they don't detach from the back of the eyeball. These other tunics here, the choroid and the retina, are only physically sealed to the eye in two places. Here at the ora serratia, which is Latin for serrated origin or serrated border, and back here at the optic disc, which is where the optic nerve comes into the back of the eyeball. The rest of the choroid and the retina are basically locked into place as a result of the vitreous exerting pressure on these two jackets of tissue. And so if you receive a blow to the head or if you lose vitreous out of the eyeball, what can happen is that the retina can detach from the back of the eye and you could lose that portion of your visual field. Okay, so that's the description of the several jobs of the vitreous. Now back to our object that we're looking at. As we pass through the cornea, through the aqueous, through the lens, through the vitreous, eventually what happens is that the image is going to be focused on the sweet spot of the retina, which is called the fovea centralis. Now the fovea centralis is important because it is the area of greatest visual acuity in the neural tunic. What happens when the light gets back here is that it actually bounces off the pigmented layer that lies right behind the neural tunic, and it's the reflection of that light that is picked up by the photoreceptors that are in the retina. And the photoreceptors are designed to respond to light. Now, there's two kinds of photoreceptors: the rods, which respond to black and white vision, basically changes in light intensity, and the cones that respond to the different wavelengths of color that we perceive. What happens on the rebound after we bounce off this pigmented epithelium, which if you've ever seen it, it looks like a dark mirror. That's my best description of it. If you ever get a chance to actually dissect a cow eye, take a peek at it, or maybe go onto YouTube and look at a cow eye dissection, and you'll see this pigmented epithelium on the back of the eyeball. It's really very beautiful. But essentially, when the light bounces back, it hits the photoreceptors that line this neural tunic, and then they synapse with bipolar cells, which synapse with ganglion cells. So there's three layers of neural cells in this neural tunic, and then eventually this leads back to the optic nerve, which feeds back into the eyeball at the optic disc, and eventually goes all the way back now to the occipital lobe of the brain, and that's what is our primary visual cortex. That's where the brain interprets the electrical signals coming from the optic nerve as sight, as vision. Okay, so that's how the light goes through. Now, anything that messes up this ability of the eyeball to bend and focus light is going to result in a compromising of vision. These are called errors of refraction. Okay, so occasionally you've probably heard of people being nearsighted or farsighted. And what happens in these individuals is that the image isn't properly bent as it passes through these different layers, and can come into focus either behind the eyeball or in front of the eyeball, and the result then is a blurry image. And so we correct this by a couple of different methods. We can use glasses to help get the proper amount of bending for the light that's coming from the object so that it hits the retina just right and you get a nice sharp focus on the image. Or you can use laser corrective surgery, where we attempt to reshape the cornea in such a way that it has either more or less bending power in order to get the image properly focused on the back of the retina. Now, in nearsightedness, essentially the defect is that the image comes into focus basically before it gets to the retina. So there's a couple of reasons that can happen. You can either have an eyeball that's too long for your head, or you can have too much bending power here in the lens and in the cornea. And in either event, what we can do is we can correct this using concave lenses and glasses, or we can use laser corrective surgery to cause the cornea here to actually flatten out a bit, and as a result, the bending when it hits the cornea actually goes instead of towards the median like this, it goes away from the median. And what that does is that increases the focal length after it passes through the lens and the vitreous, and allows it to come perfectly in focus right on the fovea centralis here, right on the sweet spot. For people who are near or who are farsighted, we have the opposite problem. We either have an eyeball that's too short for your head, or we have too little refractive power in the cornea and or the lens, and so we use convex lenses and glasses to correct for this, or we can use laser corrective surgery to cause the cornea to bunch up and increase its bending power so that now we can bring the light to nice sharp focus right back here on the fovea. So there's a couple of things that we can do to correct the vision. Probably both of y'all have errors of vision that are corrected using either contact lenses or glasses, and this is what actually is going on. Now, in point of fact, once you do this, once you either have this surgery or you put on those glasses, what happens is that you begin now the process of weakening the muscles that change the shape of the lens that allow you to focus on the objects that you're looking at. And what will happen over time is that your prescription will get worse and worse as these muscles get weaker and weaker. The other thing that's going to happen as you age is that this lens is going to get stiffer and less easy to bend, and as a result it's going to be more and more difficult for you to focus on objects that are near to you that are very tiny. Okay, and that's a condition called presbyopia, and that affects everybody, and it's basically lens stiffness. Another thing that can happen is that the retina can detach from the back of the eye. This is a phenomenon called macular degeneration. There's two kinds. There's dry and wet macular degeneration, and basically what happens in these conditions is that you either bleed behind the retina and lift the retina up off the back of the eyeball, or little masses of tissue called drusen begin to grow behind the retina and push it away from the eyeball, and the result is that you lose that part of your visual field. And so what will happen is that your brain will attempt to fill that in by basically improvising, putting in any image that it deems relevant, that would make sense. Okay, but basically you're not actually seeing what you're looking at. Okay, let's hop over here. This is just showing you the response of the pupil to light. Basically, the brighter the light intensity, the more constricted the pupil is going to become, and the reason for that is you don't want to flood out the image with excess light, because you won't be able to see anything. So you cut down on the amount of light that is actually able to enter the eyeball with constriction of the pupil. This is under parasympathetic stimulation of this smooth muscle here. In normal light, we have an average diameter, and in low light, what happens is that the pupil will dilate. This is a sympathetic innervation of the smooth muscle. As a result, the pupillary diameter enlarges, and you let more light in, and as a result, now you can see in low light conditions. Okay, the retina is composed of two layers. The neural layer is literally an outgrowth of the brain. The photoreceptor layer has the rods and the cones in it. The bipolar cell layer is between the photoreceptor layer and the ganglion layer that has axons of neurons that form the optic nerve. This is cranial nerve 2, which exits the eye at the optic disc, which we nickname the blind spot because there's no photoreceptors in that part of the eye. Now, the reason that you don't have a loss of visual field in your normal blind spot, everybody has one blind spot in each eye, is because the two eyes compensate for each other in the visual field. So the blind spot from the right eye doesn't correspond to the blind spot of the left eye, and the reason for that is that they don't lie in the same part of the visual field. So what your brain sees is a complete visual field. There's no missing visual information there. The pigmented layer helps to absorb the stray light, and it's between the choroid and the neural layer, and it's what the light bounces off of when it hits the back of the eyeball. The rods provide our black and white vision. There's about 120 million of those, while the cones provide our color vision, and there's only about 6 million of those, and they come in 3 flavors, those that respond to blue, green, or red light. Our color vision is the combined input of these 3 types of color receptors. The cones are mostly found in the central fovea in the middle of the macula lutea, and this is what provides our highest visual acuity. Our visual pathway runs from photoreceptor cells, which could be either rods or cones, to the bipolar layer, and then to the ganglion cells whose axons form the optic nerve. And this is just showing you, again, what I was telling you before. Okay, here's the pigmented layer. This is this shiny mirror in the back of the eye, this dark shiny mirror. And what happens is that the light's coming in this direction, okay, the direction that I'm drawing here. And it passes right through the vascular layer, and then it bounces off this pigmented epithelium, and then it hits the rods and the cones on the rebound here. You can see the rods because they have this rod-shaped anterior segment, and the cones have this cone-shaped anterior segment. From there, we synapse with the bipolar cells, and from there, the bipolar cells synapse onto the ganglion cells, which then send their axons back to the optic nerve. Okay, so the light comes in this way, the nerve signal goes out this way, and then back to the brain. There's 2 cavities inside the eyeball that are separated by the lens. The anterior is filled with aqueous humor. It's clear and colorless, and the fluid from it is secreted by the capillaries in the ciliary body. It's generally replaced every hour and a half, and it establishes our intraocular pressure. It maintains the shape of our eye, and it helps nourish the lens and the cornea. It drains into blood in the sclerovenous sinuses. This area is known as the canal of Schlemm. And then the back chamber is the vitreous chamber, which is filled with a gel-like vitreous body. And this is basically generated entirely at birth and not replaced. So if you lose vitreous, it's gone for good. And these are both transparent extracellular media that allow light to pass through them without being diffracted, but it is without being diffracted, but it is refracted. It is bent but not scattered. It also holds the retina back against the choroid so that it doesn't detach from the back of the eyeball. So this is just a review of how it is we see an object. We've actually already gone through this. First, we form an image on the retina. This stimulates photoreceptors in the area, the rods and the cones, and this leads to the generation of a graded potential, which eventually becomes an action potential as nerve impulses pass the information back to the cerebral cortex, primarily on the occipital lobe. Refraction is the bending of light rays to focus them on the retina. Accommodation is the change of lens shape for focus, either near or far, depending on where the object is, while constriction is the narrowing of the pupil to control the amount of light that enters the eye, and convergence of the eyeballs is used for binocular vision. Basically, these are physical adjustments to get the the best focus of the image on the back of the retina so that you see clearly. Refraction we've already talked about. It's basically the passage of light from a less dense to a more optically dense medium. This causes the light to slow down, which results in the bending of the light rays. Accommodation is basically the changing of the shape of the lens depending on whether the object is nearby or far away. Basically, the closer the object is, the fatter the lens has to be in order to see the object clearly. Constriction is the activity of the smooth muscle that surrounds the pupil to control the amount of light that enters the eyeball. And convergence is how we change the orientation of the eyeballs as the object is near or far away. Basically, the eyeballs will cross the closer the object is to your eye if you want to keep it in focus, and they will stare straight ahead for objects that are great distant. Then the reason for this is because objects that are far away, the light rays basically come in parallel to each other, while objects that are close by, the light rays have to come in at an angle, and as a result they have to be bent really, really hard in order for them to hit the fovea centralis on the back of the retina properly. Okay, refraction is defined as the bending of light rays as they pass from one medium of a single density to another of a different density. 75% of this occurs at the cornea. The lens also helps focus light on the retina. The image is inverted, but the brain adjusts and interprets the distance and the size. And so here you can see an example of refraction. Here is a light ray coming from the air and hitting the water, and notice how it bends towards the median. The median is a line that would be perpendicular to the surface of the interface. You can do this yourself at home with a pencil and a glass of water. If you stick the pencil in the glass of water and you look at it from outside the glass, it will appear as if the pencil is broken when in fact it is not. And the reason for this is that, again, the light is passing from a less optically to a more optically dense medium, and as a result the light rays will bend but not scatter. And that's a process known as transparency. Opacity is where light passes from one medium to another, and instead of being bent, the light is scattered in all different directions. Example of an opaque medium would be a frosted glass window. So here is an example of the light rays coming in from a distant object. You can see that they basically come in parallel to each other. And so we don't have to do a lot of work on the lens in order to properly focus the object on the eyeball right here on the sweet spot on the fovea centralis. But when the object's closer to our eye, we have to cause the lens to become fat. And this requires smooth muscle activity that bends the lens so that it's more convex, and as a result has greater bending power on the image, and this results in our ability to see objects close up. And we already stated that as we age, one of the things that happens to the lens is it becomes less bendable, and as a result nearby objects are harder to see, and this is a condition known as presbyopia. Accommodation is where the lens adjusts in shape for distance to allow the image to focus on the retina. For distant objects, the ciliary muscles relax and the lens becomes flat, but for close vision, the muscle will contract and result in a more convex lens. Visual disorders of refraction include myopia, again where the eyeball is too long so the lens can't accommodate enough to focus the image of distant objects onto the retina, and hyperopia, which is basically the reverse of this, where the eyeball is too short so the lens can't accommodate enough to focus the image of the near object onto the retina. Astigmatism is an irregular corneal surface which results in some parts of the image being focused behind the retina and some parts of the image being focused in front of the retina and some parts of the image being focused on the retina. And the result is a blurry image. And this usually has to be corrected with bifocals, which have components in the lens that can serve both near and far vision. Presbyopia, again, is the stiffening of the lens due to age, and it results now in an inability to see objects that are close up. So generally, what you need are reading glasses in order to look at small print. These disorders can be corrected with lenses or with LASIK. That stands for laser assisted in situ keratomileusis. Basically, what we do is we reshape the surface of the cornea using a laser beam to vaporize portions of the tissue. And what you're looking at here is just the differences in vision, in normal vision, in myopia, and in hyperopia, and the appropriate lenses that are used to correct for these different errors of refraction. Okay, so you can see how the light rays bend and what the proper use of the lens is supposed to be. Okay, let's look a little bit more at forming the image on the back of the eye. Constriction of the pupil is generally an autonomic response. This is, again, a parasympathetic innervation of these muscles to prevent excessive light rays from entering the eye. It results in the contraction of the circular muscles of the iris. Convergence is where the eyes rotate inward for binocular vision, and by contraction of the extrinsic eye muscles. Photoreceptors are those components of the retina that actually respond to the light. They generate the graded potential, which becomes the electrical signal that eventually is projected back to the optic nerve. In rods, light is absorbed by a photopigment known as rhodopsin, which splits into opsin and retinol, and this leads to the generation of a receptor potential. Retinol is basically a vitamin A derivative, so if you lack this in your diet, you're going to have inadequate rhodopsin, and this can lead to night blindness. In cones, light is absorbed by the three opsins that provide our potential for color vision. There are inherited disorders of these opsins where the red and the green cones are malfunctioning, and as a result, these individuals cannot distinguish the color red from green. Okay, if we look back at the visual pathway, we see that, again, the rods or cones synapse onto the bipolar cells, which synapse onto the ganglion cells, which eventually lead back to cranial nerve 2, the optic nerve. About half of these axons cross over to the opposite side of the brain in the optic chiasm. That's where the left and the right optic nerve cross to the other side of the brain. And as a result, what we have now is information from both eyes going to both parts of the primary visual cortex, because what we have in the optic chiasm is a condition known as hemidecussation, where about half the fibers cross to the other side and half of them stay on the ipsilateral side, and as a result now both halves of the brain, both hemispheres of the brain in the occipital lobe receive information from both eyes. And this is important because this helps to make up now a uniform visual field. The axons continue into the optic tract. They terminate in the thalamus, which then projects back to the occipital lobes of the cerebral cortex. The right brain sees primarily the left side of the object, and the left brain sees primarily the right side of the object. But as you can see, some of these fibers remain ipsilateral, so you get now information from both eyeballs on both lobes of the brain. And the reason that binocular vision is such a big deal, our eyes being in the front of our head and our occipital lobes receiving visual information from both eyeballs at the same time, is because this, among other things, aids with our depth perception. This allows us to estimate about how far away something is. And if you want to compromise your depth perception, what you can do is cover up one eye and then try and play catch with somebody. And what you'll find is it's much more difficult to judge how far away the ball is than if you have both eyes open. So this was a major advance in evolution when we had now binocular vision and the ability to perceive depth, because we could tell how far away a food item was or how far away a predator was, and as a result we could act in order to ensure our survival because we had this brand new special sense. Okay, now we're going to take a major detour here. We're going to talk about one of the other special senses. This is our sense of hearing and equilibrium. And this is formed by structures that reside in the outer, middle, and inner ear. The outer ear is made up of the auricle, the external auditory canal, and the tympanic membrane, also known as the eardrum. This canal contains hairs and ceruminous glands that protect this, basically the entrance through which this stimulus goes, the pressure wave that we think of as sound. The middle ear contains the auditory tube, which connects the throat to the middle ear. It's also known as the eustachian tube, and there are also ossicles in the middle ear which transmit the vibrations that come from the tympanic membrane to the cochlea, which allows us our sense of hearing. The ossicles are called the malleus, the incus, and the stapes, also known as the hammer, and the anvil, and the stirrup, and they're attached to the oval window of the cochlea. The inner ear contains a bony labyrinth and a membranous labyrinth that's filled with endolymph, and it's the snail-shaped cochlea, which is the organ that provides us our sense of hearing. The vestibule and the semicircular canals, which are attached to it, are our organs of balance. And here you can see the structures of the external, the middle, and the inner ear. Basically, how does sound get in? Well, sound moves through now the auditory canal. It then hits the eardrum, the tympanic membrane. The tympanic membrane will wiggle. And when the tympanic membrane wiggles, the malleus or hammer will whack the anvil, which will cause the stirrup to vibrate. And as the stirrup vibrates, what happens is that it pushes fluid through little canals inside this cochlea. Basically, the fluid is pushed in one direction and the pressure is relieved here at the round window. But as this fluid's being pushed through this sort of swirling tube, what happens is that there is a membrane inside here upon which rest sensory hairs, and these sensory hairs will start to vibrate up and down, and the region that vibrates up and down will depend on the pitch of the sound, and the amplitude with which they vibrate up and down will depend on the intensity of the sound. And so this provides our sense of pitch and loudness. What happens when these hairs start bouncing up and down is that they hit their heads on the top of a sort of a flap of tissue, which we call a tectoral membrane. And when they do, what happens is that they tilt to one side and they open ion gates that produces an electrical signal that eventually heads back to the 8th cranial nerve, the auditory nerve, also known as the vestibulocochlear nerve, which then projects back to the temporal lobe of the brain and provides our sense of hearing. Okay, so that's basically how we hear. Now, our sense of balance comes from two different organs. It comes from the semicircular canals. You can see the three semicircular canals here. And it also comes from the vestibular apparatus. And basically, that's this sort of bulgy looking area that is just superior to the oval window, and it provides us our sense of static equilibrium, while the semicircular canals provide us our sense of dynamic equilibrium. Well, what's the difference between the two? Well, dynamic equilibrium is the sense that we get that our body is moving in some direction, either up, down, left, right, or back and forth, or around and around. While static equilibrium is our sense of orientation in space when we're standing perfectly still. And to make a long story short, the way that these two areas of the vestibular apparatus work is that for our sense of static equilibrium, basically gravity pulls on sensory hairs that are embedded in a gelatinous matrix that has little calcium crystals embedded in them called otoliths. And as the gravity acts to pull these otoliths towards the gravitational center of the Earth, that gives us our sense of up and down. Okay, what's superior and what's inferior. When we move, our sense of movement is provided by the moving of fluid inside one of these or more than one of these three semicircular canals, which cause sensory hairs that are embedded in a membrane in each of these canals to move up and down, which causes them again to open an ion gate, which produces a graded potential, which projects back to the temporal lobe of the brain through the eighth cranial nerve and provides us our sense of balance, okay, while we're moving. So it's essentially the same mechanism, but the stimulus is different. Here it's sound in the cochlea, here it's gravity, and here it's movement, okay, but it's still the same idea. These hairs move, and as they move, they open ion gates, and those ion gates produce an electrical signal that our brain perceives as either sound or static or dynamic balance. Okay, while we're on the topic, this little tube here, the eustachian tube, is very important because what it does is it equalizes pressure between the external and the middle ear, and this allows the tympanic membrane to vibrate freely so that we can hear. If this tube becomes occluded, what can happen is that you can either trap bacteria in here in the case of an ear infection that can cause the tympanic membrane to distend, and this results in a condition known as otitis media, basically earache, and you have terrible pain, and you also have a diminished sense of hearing. If there's a vacuum created here, the tympanic membrane gets sucked back against the middle ear, and it just becomes difficult for you to hear. In children, this is often corrected using tubes that are inserted into the tympanic membrane to equalize pressure, and this restores now the ability of the tympanic membrane to vibrate freely. It also introduces more air into the middle ear, and this retards the growth of anaerobic bacteria that often contribute to otitis media. So you get a little extra bang for your buck there. Occasionally, when you have otitis media, what can happen is that the pain produced here can become so intense that the doctor will attempt to treat it using megadoses of antibiotics in an attempt to kill the bacteria that are now growing back here. Often this fails to work, and the eardrum will rupture, resulting in discharge of fluid through the auditory canal and an immediate relief of pain. The problem here is that when the eardrum grows back, it has scar tissue in it, and as a result, it's less responsive to sound, and so your hearing is diminished. A little trick that I've learned, if you want to relieve the pain produced by an infection of otitis media, if you don't happen to have any topicals around or any good painkillers, you can relieve the pressure by creating a vacuum in the auditory tube. The way you do that is you can close your nose and your mouth, and you can inhale, and what that'll result in is a vacuum that can pull some of this excess garbage out of the middle ear, can remove some of the gas that's created by the bacteria as they metabolize, and this can temporarily relieve some of the pressure and the pain. You know, it's not a cure, but it can give you a little bit of relief until you finally do get to the doctor and he treats the condition. In the old days, the way this was treated is by lancing of the eardrum, which is basically taking a long needle and poking a hole through this piece of tissue and allowing the fluid to drain out. They don't use that method much anymore. It's contraindicated. They prefer to do antibiotic treatment as a way of avoiding now the problems associated with otitis media. You can also have an inflammation of the external ear. This is called otitis externa or swimmer's ear. And what it does is it occludes this canal, and it results now in a difficulty in hearing, but it also is very painful. It's generally treated with an antibiotic wick and anti-inflammatories in an attempt to reduce the swelling and kill the bacterial infection. Okay, let's talk a little bit about the vestibule. The vestibule includes two sacs, the utricle and the saccule, and semicircular canals, which are arranged at right angles to each other that contain membranous semicircular ducts, each of which ends in the ampulla. The cochlea has three levels: a cochlear duct, which is membranous and contains endolymph, It also contains the spiral organ for hearing. Above is the scala vestibuli, which ends at the oval window, and below is the scala tympani, which ends at the round window. The spiral organ sits on the basilar membrane, which is the floor of the cochlear duct, and it contains supporting and hair cells, which are covered with the tectoral membrane, and these are the receptors for auditory sensation. They synapse with sensory neurons in the cochlear branch of the 8th cranial nerve. And here you can see the organization of this organ. These are the semicircular canals. This is the semicircular duct. This is the ampulla, and this is the utricle. And then if you look down here, you can see the saccule. Okay, so these are our vestibular organs here. Vestibular organs. Our organ of hearing is this sucker right here, the cochlea. And you can see here a cutaway showing you the scala tympani, the cochlear duct, and the scala vestibuli. And it's the hair cells that basically sit in this membrane right here. Now, if we take a cross section of this and we zoom up on it, so basically we take a lateral cut here, and we're looking at this region right here, and we want to see the actual receptors that respond to the sound. This is what we see. This is the tectoral membrane. Okay, these are the inner and these are the outer hair cells, and basically when the fluid is moving around this tectoral membrane and around this basilar membrane, what happens is that these hairs will start bouncing up and down, okay? And eventually what will happen is that this inner hair cell will have these little tips, okay? These are the hairs up here. These are the actual hairs. These tips will open these ion gates, and that'll produce the graded potential that heads back to the 8th cranial nerve, okay? These outer hair cells are basically stabilizers. Okay, so that's the mechanism right there. So this is what I mean when I was trying to tell you that these little hairs, they bounce up and down like this, and when they hit their heads on this tectoral membrane, that's when they pop these gates open and make that electrical sound, that electrical stimulation that we interpret as sound. Okay, so how does this work? Sound waves in the air enter the auditory canal, which hits the tympanic membrane, which causes the movement of the ossicles, which hit the oval window. This produces pressure waves in the perilymph that are conveyed from the scala vestibuli to the scala tympani, and the pressure waves in the endolymph cause hair cells to bend against the tectoral membrane. Neurotransmitter is then released to the sensory neurons, and depending on which area of the basilar membrane is stimulated, we either have high or low pitched sounds, and the volume is going to depend now on the intensity of the waves, how vigorously we go up and down at a particular pitch. And this is just showing you how the sound waves hit the tympanic membrane, how the ossicles wiggle, how the perilymph is now moved around and through these membranes. Okay, this is the cochlear duct. Okay, this is the endolymph that's in here. This is the perilymph that's out here. But basically, these pressure changes in the perilymph are transmitted to the endolymph, and this is what causes now this middle layer here, the tectoral membrane, to wiggle, to go up and down. Okay, there's the basilar membrane, there's the scala tympani, there's the scala vestibuli, and right there's the vestibular membrane. Okay, this is what responds to again the changes in these pressure waves, these sound waves. Okay, so here you're looking at the progression. So there's the sound. Okay, there's the ossicles. There is now the jiggling of the oval window. Okay, and then eventually what happens is that we make it to in here into the perilymph. Okay, we keep going. Now notice that we're starting to affect now the endolymph. Okay, from there we head straight through, again depending on the pitch. Okay, The high-pitched area and the low-pitched area lie in different parts of the membrane. And then eventually we head around, okay, head back, and the pressure is relieved now at the round window. If we look at the auditory pathway, cochlear neurons, which are in the 8th cranial nerve, end in the medulla. They're usually on the ipsilateral side. The midbrain then receives the innervation from the 8th cranial nerve that projects to the thalamus, and then we hit the auditory cortex in the temporal lobe of the brain on the ipsilateral side. Each side of the brain receives input from both ears, so again we have hemidecussation. We have some fibers that cross over and some that stay on the same side. Equilibrium is essentially the same mechanism inside the organ, but the stimulus is different. Static equilibrium provides our sense of position in space relative to gravity, such as when your head is tilted or a car is speeding up or slowing down, while dynamic equilibrium provides our sense of position in response to the movement of our head, such as when we spin or when we accelerate or decelerate. Static equilibrium is sensed in the maculae of the utricle and the saccule. Basically, gravity pulls on otoliths in the otolithic membrane, which bends hair cells in this membrane, which opens ion gates that generates a graded potential that projects back to the vestibular branch of the 8th cranial nerve and then back to the brain. Our dynamic equilibrium is provided by the semicircular canals in the inner ear. They're located at right angles to each other. The cristae in each ampulla have hair cells that are embedded in, again, an extracellular matrix called the copula. The supporting cells help nourish these hair cells, and essentially what happens is when our head turns, the hair cells will move, the endolymph will lag and bend the hair cells, and then these nerve impulses will project back to the vestibular branch of the 8th cranial nerve, and then eventually to the temporal lobe of the brain. Axons from the vestibular branch project to the medulla or to the cerebellum, and then from the medulla we project to the nerves that have motor control over the eye, the head, and the neck, and the spinal cord tracts for adjusting the muscle tone and postural muscles are basically depending now on the input that comes from these equilibrium pathways. And this is what allows us, for instance, to fix our gaze even when our head is moving. This allows us to track a moving object in a uniform fashion because we have now an intimate interaction between the medulla oblongata, the cerebellum, and the cortex of the temporal lobe. And basically what happens is that we're able to coordinate now what we're trying to perceive and what we're perceiving with what we're actually doing. Okay, so this is a very important role for the cerebellum, being able to coordinate now both equilibrium, visual input, and balance all at the same time, and also auditory input. Okay, that brings us to the end of chapter 19. And I'll see y'all in class.